Okay, so you see all these fun models up here. What speech pathologist doesn't have a toy bag? These are my toys for today, so I hope some of the videos on my slides are not going to show because I didn't convert my Google Slides to PowerPoint. So I'll try to use the demonstration over here. We'll talk about some things here, but we are going to talk about the Pediatric Airway and how it's a shared superhighway, and there's a lot of intersections and there's obstacles in speech-language pathology that cross over with dental, orthodontics, ENT, oral surgery, and so that's what we're going to talk about today. So I'm going to skip over a lot of this introduction since Dr. Capitan gave me such a nice one, but I am in Western North Carolina. And my practice is Carolina Pediatric Therapy. This is a beautiful road. It's my favorite road. Do you guys know what this road is? The Blue Ridge Parkway. It is a beautiful road. It's now open again after a year of having lots of construction, but a really great metaphor for our airway. A lot of interesting things. I love research, I love leadership, healthcare, and education, those kind of things. Interprofessional collaborative practice is part of what when I was doing my PhD work, looking at a lot of complex presentations and how do the different teams work together. So my practice, this is my team. And this is just my leadership team. My actual team is about twice the size of this room. And every Friday morning about this time, actually right now, they're all meeting together to do something very similar to what we're doing today. We meet together for learning collaboratives. We block off, we don't see patients from 8 to 9 o'clock on Friday mornings because we think this right here is very, very important. So thank you for talking about that connection because it is really, really important there as well, and we really appreciate it. We have about 80 practice members, and we do speech, OT, PT, we do psych, social work, and counseling as well, so all of those disciplines. So here, one of the reasons for this symposium is that mentoring, that connection, and this phrase, the best way to experience the exhale throughout the day is to experience joy and social connection and the positive effort of our work. And so I hope that today, as you guys are all connecting, that the mental health component is a real thing. It's a real thing, and burnout is really high in helping professions. And so part of this together is us getting together and learning from each other. So that also helps us with our burnout and our well-being. So our learning objectives today are, we're going to look at the intersections of the airway structure and function. We're also going to look at, oh goodness, my slide is not advancing. There you go. Okay, let me get them all up there. Okay, all right. So we're gonna look at the shared structures together for those intersections. Then we're gonna look at some obstacles that we encounter in speech-language pathology, and then the intersections of our care. So the first thing we need to do is breathe. So can everybody do that? Okay, we're gonna breathe in through our nose and out through our mouth. The next thing we're gonna do is we're gonna go breathe and we're gonna say, ah, ah. Everybody do that. Okay, do you already feel better? Okay, do you know what we just did there? We just calmed our autonomic nervous system. Right? We just calmed ourselves. Our breath is so important. It's the foundation of life, and we really need to be focused on that in the day. When we do this collective breath in calming our nervous system, a lot of our kids are in this, that have airway issues, are in this kind of low-grade autonomic nervous system fight or flight response. Have you guys had those in your office? Kids come in, fight or flight? Yeah? How many of them love to come to the dentist? I love to get their appliances fixed. Yeah, so for our kids with airway issues, they really can be in this fight or flight. So one thing we do is we want them to come back to the breath. The other thing is, everybody grab your drink, take a little sip, and swallow. Okay, so right there, a lot of highly complex things happen all at once. So our airway is really complex. It's highly precise and it's coordinated. And so I like to look at it as a road, which is really fun. This is another tunnel on our Blue Ridge Parkway. But the airway is a super highway because it's a two-way passage, right? Air's coming in, air's going out, food's coming in. Hopefully food's not coming out, but sometimes it is coming out the same shared passageway. There's a fork in the road. There are 3 gates that regulate the passage of the different things. Okay, there's 2 in the airway, but there is 1 going into the esophagus, right? So we've got things opening and closing and coordinating. So opening and close with precise timing, coordinating with over 30 muscles, 6 cranial nerves. So there's a lot going on there. And they're under both reflexive and voluntary or volitional control. So you don't probably think about breathing and how many times a day you swallow, but it happens just kind of reflexively all day long. You also can make yourself swallow. Let's think about it. Can you swallow right now? Just the saliva in your mouth? Right, we can do that. So it's under volitional control as well. So it's designed for efficiency and precision, and that shared space equals some shared vulnerabilities for breathing, feeding, and speech. So the shared functions of this pathway, we've got respiration, feeding and swallowing as far as protecting the airway during bolus transit, and then that phonation and speech where we're converting airflow to sound through the larynx and the resonators. So there's 3 subsystems to speech and voice, and this is where the air pressure meets precision. There is power. Okay, our power is in our respiration right here. Okay, and then we have a source. There's a source of the sound, and that's in our larynx here in the giant-sized version. This is as big as my head right here. You can see we'll look at that a little bit more. And then there's a filter, which is our head space, okay? It's our pharynx, it's our oropharyngeal cavities. That's the filter and the articulatory components of our voice and our speech and swallowing systems. So first of all, the power, okay? The speech is really, this is a hidden powerhouse here. So our voice runs on air. Do you know which kind of air? Is it inhale or exhale? We speak on, we talk like this, no, we don't talk like that. Oh, we don't talk like that, right? The little kids, have you seen little kids do that before? That's really funny. No, we speak on the exhale. So we take a big breath in, and then when we breathe out, that's when our vocal cords can vibrate and we can speak. So this functions to provide that subglottal air pressure, and that speech is really shaped exhalation. So that's really, really neat. Every word that we say begins with a controlled airflow from this little muscular dome right here. Looks like an umbrella. It flattens out when we breathe in, and it goes down, and then we breathe out, it goes up, okay? And we kind of compress our airway. So it looks like a little umbrella. Here's another little demonstration of it if you want to see this little image as well, showing that little umbrella pull up, pull down. So the next part is our larynx, and I think this is the most fascinating instrument. I mean, you know your voice is an instrument, right? My daughter is in music school, and one of her primary instrument is voice. Her secondary instrument is guitar. Okay, and our airway functions a lot like a guitar. So in our larynx here, this is the part here. It looks like this, a lot of good things, cool things going on, and it is a magnificent instrument. It is also a protector, okay? So it closes off, it raises up, our epiglottis lifts over, so when we swallow, this little epiglottis right here is gonna flip over and it's gonna protect the airway while it makes a little chute so the food can go down that other gate, right? So this is a really amazing contraption. Also, the muscle here, when we tilt forward, that lengthens those cords. Can you guys see the cords in there? So that lengthens like a guitar tuning peg does to a string. Okay, so our larynx is this amazing mechanism here where the vocal cords are vibrating at very rapid rates. 60 hertz is at our lowest. Sometimes we can get to 1,000 hertz, and 1 hertz is 1 repetition. Okay, and so 60 hertz is 60 times per second, and that's in a low bass voice. A child, their voice is 1,000 hertz. That means 1,000 times per second. As a kid squeal, that's 1,000 hertz. So it's really amazing, this mechanism here of our larynx, and it protects as well. All right, so this shows the range. So the range of our voice can actually cover 5 octaves on the piano. How many musicians are in here? Do they play the piano? No one in this room? Whitney plays the piano. Okay, good. All right. So it is definitely an instrument. And then we have the resonatory and the articulatory filter part. So that's here in our head space, right? So we have our oral nasal cavities, our articulators, our lips, our tongue, our teeth, and that is shaping and sculpting that air. So we have the pharynx is really like a mega amplifier, and it changes the column of air that comes up through our lungs. It changes the shape, and it can really make our voice seem brighter, or our voice can seem darker. So did you know, this? You dentists will appreciate this. You know that your smile actually does make your voice brighter because it changes the shape of those articulatory and those resonant spaces. So when you smile and you say, hello, this is Carolina Pediatric Therapy, that is a very bright voice. Or you can say, hello, this is Carolina Pediatric Therapy. I just changed the shape of my pharynx to make, and my entire oral cavity to make that voice sound brighter. So it is really like that box part of the guitar in the way that it changes sound depending on the way that we do it. And we do it in microseconds over and over and over again. Just let me see if I have some stats here. Let's see. Do you know which 3 sounds in the English language need to have the palate open? Most of them have to have that palate closed. Do you know which ones need it to be open? Oh, the speech pathologist, yes. I know it. That's exactly it. Yeah, there are 3. M, N, N, G. Those are the ones that are going to have your palate open. All the other ones need the palate to be closed because we're directing and sculpting airflow out of the mouth, okay? So I hope you're seeing yourself in this as dentists and as orthodontists, oral surgeons, starting to shape the structures where speech and resonance is happening. So it's really an air pressure system. This air pressure flow phenomenon is the subglottic pressure has to exceed the supraglottic pressure to initiate phonation. The glottal resistance regulates that pitch and intensity. And then our airway patency and how open it is really going to influence the efficiency of the sound energy that is produced. And so it is just a beautiful instrument. I love it. That's why I have models of it. I just like to stare at it. It's lovely. I know most people don't have this in their house and in their office, but I love this. This is great. Little kids like to see what's going on inside of their body, and so this is a cool way to show it as well, to say this is what's going on here. So very fun. So airflow to speech again was inspiration, phonatory onset, resonance, articulation, and then all the same time there's airflow protection happening. There are a lot. I wanted to show that there's, do you know how many words a day you guys speak, most people? So vocabulary, some people more than others, yes. So some people, okay, so our vocabulary is between 30,000 and 60,000 as an adult, all right? In a day, typically you're gonna use about 16,000 words. That's a lot taxing on the system, right? Professional voice users, speakers, clergy, therapists, teachers, they have a lot more. Sometimes they will upwards of 30,000 words a day for professional voice users. So you can see that there can be some taxing on the system. When there's an airway issue, we're going to have a little bit of trouble in these areas. So, with kids, some pediatric differences. You're going to have a shorter pharynx, higher larynx, flatter palate. Airway structures are smaller, softer, more reactive, and minimal swelling in these areas from edema, any kind of infections, allergic rhinitis, those kind of things. Any of those minimal swellings are going to have issues with airway control for voicing, subglottic pressure generation for that speech intensity and loudness, and then airway protection in the swallow. There is a developmental shift here. So the infant's larynx descends around 3 to 4 months. So at first, it's up there, it's little and fat and flat, and you guys know all of this. As they start to grow and descend, that actually increases their choking risk. Because now, as the larynx descends, there's more space in there for food to kind of slip in the wrong way. Interestingly, as this increased complexity happens, there's more potential traffic there. And this really aligns with motor development. And as movements become more complex, as the foods that kids eat becomes more complex, their oral cavities change and these structures change and it becomes more complex. But there's some possibilities for some trouble there if there's some airway problems. So for speech and pediatric airway, a healthy voice equals efficient airway use. Okay, so it reflects how well the airway can manage pressure and flow while protecting itself. And our dual focus in speech pathology is going to be optimizing the airway efficiency for communication and then ensuring airway protection. So some obstacles that we come across here, usually they're obstructions, if we're thinking about a road analogy, some obstructions, some restrictions, some structural things. And obstruction is going to be the blockage of airflow. Restriction is going to be more reduced mobility or space. And then structural is going to be congenital or acquired differences. So some common airway-related obstacles that we see, adenoid tonsil hypertrophy, laryngomalacia, tracheomalacia, tethered oral tissues, and then cleft and craniofacial anomalies, and also VP insufficiency and incompetence. So those are some things that we see in airway. The impact on speech, voice, and feeding. If there's obstructions, there's going to be reduced airflow. We're going to see weak voice, limited phonation time, feeding difficulties. Often we'll see fatigue, reduced oral motor practice for speech. If they're tired, if they're fatigued, if they're not getting as much feeding practice because feeding is difficult. And then resonance changes. We may see hypernasality, like really nasally voice, some nasal emission as well with resonance changes. And then that early airway management really supports the speech and language milestones. So here's this epidemiology snapshot. There are a lot of statistics here. I'm not going to read all of them, but just in looking at these, this really just shows, the kids we see for articulation, feeding challenges, if they have underlying airway involvement, many of those are really related to the airway, and they can start in the dental chair, they can start at the ENT, they can start with the pediatrician. Sometimes the speech pathologist figures this out through listening to the speech, but sometimes you guys are the ones seeing them in the dental chair and seeing that. Let's see, let's skip through those. So this one is just from the ASHA website for speech language, is 1.6% of US children 0 to 17 have feeding and swallowing disorders. Up to 70% of those with airway anomalies, they show dysphagia before surgery. And then the true incidence is underreported. Many of those present first-year dentists, the pediatricians, for mouth breathing or poor growth, and then feeding and airway issues that are commonly occurring with speech delays. It just kind of shows us, recognizes our shared responsibility there. Okay, so let's talk about obstructive ones. I'm just going to touch on a couple of them, or really one of them, in each category. So this adenoid tonsil hypertrophy. So the dental and the facial features of these, we're going to see a long face, open bite, narrow maxilla, high narrow palate, narrow nasal cavity. For speech and feeding and quality of life, we're going to see hyponasality. Kids are going to sound like they have a cold, imprecise articulation. We see oral resting posture changes, some drooling, we might see that. With poor sleep, snoring, chronic mouth breathing, obstructive sleep apnea daytime. This is a big one too. A lot of kids will come in to our clinic and they'll have behavior issues and things going on. We ask about sleep because obstructive sleep apnea, tonsils, adenoids, that's a leading cause of obstructive sleep apnea in children. And so that focus really, we want to get them to an ENT for a consult there, check audiology. We also see otitis media with effusion happen when we have enlarged tonsils and adenoids. Hearing is really important for speech as well. And so when we see these things happening in the airway in an obstructive way, that is going to affect speech and language development as well. So we also have orthodontic monitoring. We'll send them over to ENT audiology, some nasal breathing retraining with speech, possibly orthodontic monitoring and facial growth and sleep medicine. We can bring all of those folks in. For restrictive obstacles, we've had such a great teaching on the tongue tie, so I won't talk any about this except for just to acknowledge that that is a restrictive obstacle that we do come across. We see those high arched palates, restricted oral expansion, and then speech, feeding, and quality of life. Again, we see open mouth posture, difficulty with lingual sounds, some early feeding inefficiencies, and risk factors for sleep disorder breathing, and OSA as well. And then our collaborative focus there is to work with you all and our tongue release folks, and then we do pre and post support there as needed. So some potential dental ortho impacts here. You guys know all of these. And then we have structural obstacles. So this road is obviously not drivable. So we're going to see some structural obstacles. And in this area, we're looking at cleft lip and palate, craniofacial anomalies. And these, of course, we're going to see some different malocclusions, dental anomalies, altered maxillary growth as well. And then in the speech world, we're going to see VP insufficiency, fistulas. We deal with those a good bit, hypernasality, some compensatory misarticulations, nasal air escape, feeding difficulties, a voice, hoarseness, and then vocal nodules due to strain in the airway. When we have some inefficiencies in those structures, we will often see strain on the vocal cords here, and we can see some hoarse, raspy voice because kids are pushing really hard to get that subglottic air pressure. Our collaborative focus, of course, here is the craniofacial team. So we don't operate in a bubble. We don't do this alone at all. And so sometimes speech pathologists will find a cleft, a hidden cleft, submucous cleft, where we didn't know that it was there. But often they're coming to us already having been a part of a cleft team. The timeline with our cleft kids, we're from birth all the way up to age 20. They're being followed the entire way. For that, there are several different versions of the VPI or the VP dysfunction. There are cleft VPIs, and then there are non-cleft VPIs that we're working with, of course, with the velopharyngeal insufficiency, the unrepaired clefts, and then some post-surgical insufficiencies after, say, we had a tonsillectomy, adenoidectomy. We might see some hypernasal speech. Sometimes it's temporary and resolves on its own. Sometimes we need a little bit of support to reteach the palate to reach a little bit further because we just removed some tissue back there in the back. So with the non-cleft VPI, we have some inefficiencies, insufficiencies, incompetence with some motor, with CP, with Down syndrome. Those you might see some different VP incompetencies. And then VP mislearning. In speech therapy, a lot of this we're working on the VP mislearning that's affecting their articulation patterns. So the cleft lip and palate changes the nasal and oral airway geometry. The way those sound waves go through the system impacts suction, nasal airflow, and speech resonance. And then surgical repair really is improving that structure. And then the SLPs are addressing the VP function and how that affects articulation. We're really trying to get that airflow to go and direct out orally. Sometimes it's coming out of the nose and we just need to retrain. And sometimes it's structural, and therapy isn't going to be as helpful when the structure is not there. Okay, it's just like that road where the bottom of the road is falling out. You cannot walk across that road because the bottom is falling out. So we need structures to be adequate. We need them to work in order for the speech therapy to work. So we often are referring kids to have consults for those things. My videos sadly do not work today, so I'm going to go forward, but Leslie, I know, has some great videos this afternoon on cleft. So, sadly. This little guy is JP, just so you can do you guys, what do you notice about this one? Just about his bite. Say it again.
Class 3.
Yeah, class 3. Yeah. Let's everybody try to do your F sound. Go fa 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 fa. What happens in your F sound? What do we bite? Right. So what is going to be difficult for this kiddo with this class 3 malocclusion? His F. Yeah, his F is going to be really hard. You know what we've had to do with this one? Because his structures are not available to him to do fa, 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 or va, va, va. A lot of these sounds. We are teaching an alternate acoustically correct production. He's doing it like this. Fa, fa, fa. Try that. Do fa, fa, fa. It's about the same. Fa, fa. Acoustically, if you look at it, it looks different, right? But for kids who have these class 3 malocclusions, where we know that surgery is not going to happen for a while, he's got a lot of growing to do. We're not looking at any kind of maxillary advancement at this point. We have to work with the structures that we have. And so a lot of times in speech therapy, we can still give them acoustically correct productions, even if the structure is, you guys have a lot of work to do in the dental and the orthodontic world before he has structures that are going to be in the right position to produce the sounds visually the way that they're supposed to look, but we can help with that. So that was the video that I was showing you here, was that production of the sound. Let's see. So the intersections of collaborative care here, who is our airway team? We have a lot of providers on the airway team. Right, you all included. We have patients, we have primary caregivers, pediatricians, SLPs, lactation consultants, physical therapy. I was so excited to see your data. Dr. Singh, where are you? The data about the body work. Oh, the body work. Just the body work was better than all the other things combined, which is fantastic. Way to go, PTs. I'm excited to hear from Nikki this afternoon. The body work is really exciting there. And then, of course, our ENTs, our craniofacial surgeons, dentists, orthodontists, you guys are all so important to the structure, the function of speech and voice and in the airway. Our pulmonologists, our sleep apnea folks, and our allergists also are really important to us, helping us with obstructions and those sleep things, because the cognition is really affected when sleep is affected. So we really want to get kids in and get any of those obstructions dealt with so that they're getting good sleep, so that they are ready to learn, they're in that calm alert state, they're not in fight or flight, and their brains can actually learn in those occupations of childhood, in school and at home. So for the standards of care, what we know that works, structural intervention plus functional retraining, that's what equals durable results. Post-expansion or release without therapy, there is a risk of relapse or patterns, maladaptive patterns continuing. Happens all the time. The structures are fine. The two of the kids I wanted to show you on here, their structures are fine. There's no reason that they should have hypernasality happening, but they learned it that way because they were compensating for the fistula that they had, the palate that wasn't quite repaired yet, and they learned all of their sounds while they didn't have great structure. And now we have to go back and repair and teach those muscles, that neuromuscular component, how to work. And so that's why it's so important that we pair the structural work that you all do with the functional work that we do in therapy. And that follow-up is really, really important, that we communicate and connect together. The coordinated assessment, your dentistry, ortho, surgery, those CBCTs, occlusion, airway volume measurements, the ENTs looking at that nasal patency, the adenoids, the tonsils, the laryngeal status as well, and then the SLPs are looking at the oral resting posture, swallow breathing coordination, resonance, articulation, and those kind of functional pieces. And that cross-disciplinary screening really captures both form and function, which is what we want to see. So coordinated intervention before the structural change, it is great to do baseline. So baseline feeding assessment, if you're like, hey, I'm about to do some change, let's go ahead and get that evaluation on the front end. Then we do the structure, then we follow them after, and you can really see the results of that intervention that you've done. So after the surgery expansion, we'll retrain that tongue resting, that nasal breathing, the swallow sequencing and that lip seal, and then resonance and articulatory balance. We're working on all of those things in that coordinated intervention. The core intersections of care, our speech outcomes reflect that structure, function, and habit pattern. Open mouth posture, low tongue resting posture influence the palatal width and arch shape. Okay, so our function is going to affect you all in orthodontia. We're going to make sure that if the tongue is in the bottom of the mouth, that is going to affect what the palate looks like. And so is it the chicken or the egg? And we're going to learn that this afternoon, and I'm excited about learning that as well. Which comes first? Function or form. So early VP function affects pressure consonant development, okay? So if we have an open palate, it is going to affect how the child learns those consonants. T, D, but T, D, K, all of those sounds, those are pretty early sounds. And so if you've got an open palate while you're learning that developmentally, they're gonna learn it in a way that is incorrect and that we need to support in speech as it's finished, as it's being fixed. Of course, otitis media, hearing affects speech clarity as well. With our kids with airway issues, a lot of times they have hearing issues as well because they have fluid in the ear. Did you know that your middle ear transduces 30 decibels of sound? 30 decibels. So think about that. That's like putting water and cotton in your ears and then trying to listen to somebody say something. You're not going to hear all the frequencies of the speech sounds and the noise around you, and that is going to affect the speech clarity and phonological patterns. It's why folks who are deaf or hard of hearing, their speech has a very distinct sound, is because they're not hearing all of those sounds, and then they don't have that feedback loop to produce. So hearing is really, really important in speech and language development. Therapy is not just articulation, it really includes the airway, resonance, and the oral postures, and then that close coordination guides timing of palate revision. So let's see. Oh, I am about out of time here, aren't I? We have some shared concepts here. I'm just going to zip right through this because I'm out of time. And really, the collaboration between SLPs and PEDS specialists is the most important part of all this. Airway management is most effective when we all work together. I know you all do some airway dentistry, airway orthodontics as well. That all being coordinated together is really, really important with all the disciplines. And then regular interdisciplinary communication can really improve patient outcomes. Just one last thought on this is airway difficulties can cause child and parental anxiety at any level. If you're seeing obstructions, restrictions, structural issues, if the airway is compromised, we cannot breathe, we cannot function. So if breathing is compromised, you're going to see some anxiety there that we have to work through. Peds dentists, orthodontists, and oral surgeons can provide that balance for families, and SLPs can really help support that. And if you can, if the anxiety is really contributing to or interfering with the care, getting psychology involved, getting behavioral health involved is really, really important because they can help work through some of those anxieties that kids and families have around the care you provide, and that's going to help you to provide better care as well. So again, the shared superhighway map, we've got dentists, you guys are expanding and repairing the lanes, ENTs are really clearing the traffic, and the speech pathologists we are training the drivers. Okay, we're training the drivers on the road, and that team coordination really creates some smooth traffic flow there. And thank you guys so much for listening.